Until now, we were talking only about the disc-related pathologies. Another very common aspect in our spine practice is the osteoporosis and osteoporosis-related fragility fractures that we come across, especially in the elderly females and with increased longevity, even in elderly males who are in their 70s and 80s. So my next talk will be based on how to understand these fractures and how to choose which ones to treat aggressively, which ones to treat conservatively, and what methods we can apply. So we all know vertebral compression fractures can be either osteoporotic or they could be pathological, arising out of some kind of pathology within the bone, that is multiple myeloma or secondaries, or it could be traumatic with a moderate degree of trauma, even when there is not much of osteoporosis, but you can sustain some kind of compression or burst fractures, especially when you fall down from stairs. Mostly the osteoporotic fractures are of three types. The most common type is the wedge fracture. The second is biconcave, where both the end plates get squeezed together, and then the third type is the crush fracture, where there is a general crushing of the whole vertebral body. Lot of the fractures they collapse acutely, and some of them do not collapse acutely, but they may progress over a period of time, and we need to watch over them for the signs of further collapse and progress, and whether there is any subsequent migration of the posterior superior fragment into the spinal canal or not. Though it is not very easy to predict. Of course, burst and unstable fractures are easy game, but we are talking of those deceptively looking stable fractures in the beginning, which ultimately become unstable or go on to have non-union, and they become the source of trouble. You feel very confident recommending that you will do well in the beginning with conservative measures, but as the time passes, the fracture doesn't heal. The patient has already spent 6 to 10 weeks in bed rest, and then when the time is there for patient to get up and start moving, what we find is that the fracture still has not healed. It has led to a vacuum, water fluid collection within the vertebra, and collapse on dynamic x-rays. I'll talk about them later. So if we could find a way how to predict these fractures, life would become much easier. So we go back to this nice paper published in 2005 in Journal of Spinal Disorders and Techniques. So based on a lot of fracture patterns they saw, they identified 5 different fracture patterns, and out of them this guidance was created. It acts as a guideline. Now, it could not be an absolute thing, but yes, you can use, and we've been using this particular guideline with a fair amount of accuracy in our plannings for recommendations. So if you look at the upper two, the first two are concave type and dented type. So in concave, only the superior end plate just caves in without much crushing, without much damage to the anterior cortex or to the inferior cortex or to the posterior cortex. The second is a dented type, where the anterior cortex of the vertebra tends to have a small notch here, which is inwards, that is posteriorly directed. These two fracture types are usually associated with good outcomes if left alone without any aggressive treatment. Just give a little bit of bed rest, analgesics, and rehabilitation measures at the earliest as the patient tolerate. But if you look at these 3 fracture patterns, especially the swelled front type, you will realize that this looks very innocuous in the beginning, especially when you see in your x-rays, first day x-rays, they will look, the height is reasonably okay, there is a fracture, and the patient gives a history of severe pain, and many a times you diagnose these fractures more on MRI rather than, or either on your clinical suspicion than on x-rays, because there is not much of crushing, there is not much of loss of height. So the swelled front type. The second is the bow-shaped type, in which in addition to the caving in of the superior end plate, there is some kind of a denting of the anterior cortex. So this is a combination of these two. So this again puts these cases to a different risk group. And then the third one is a projecting type. That means the anterior cortex, similar to the soiled front, but there is a sharp notch which is not posteriorly directed but anteriorly directed. So these three, when they have followed these cases, they found that these 3 types are usually having poor prognosis if left alone. So if you are confident to treat these cases aggressively, right on day 1, you can choose to recommend some kind of a augmentation procedure for these cases. If the patient doesn't want, that's their call, but at least you can tell them that you are less likely to heal and you are more likely to heal. So these guidelines can come handy in our day-to-day practice. Just example of the dented type. This is a typical dented fracture, in which this X-ray shows remodeling, very nice, complete healing at 2 years. Swelled front type fracture, you see the swelled front here, and as the time passes, the fracture vertebra starts collapsing and then allowing the local segmental kyphosis. Similarly, the bow-shaped fracture, you can see there is a dent here and there is a caving in of the superior end plate, and what happens to it a few months later? You can see there is an intravertebral vacuum, the body has collapsed. Projecting type, again showing the same outcome few months later. You could see this was the initial fracture, projecting type, and then you can see the height. This was a previous fracture. This is not, this one is not the, this is L1. So you can see L2 was looking like this in the projecting front in the beginning, and see 6 months later or 4 months later what has gone wrong. So if you are able to identify these patterns right on day one, because once they reach this stage, they may not be amenable to simple augmentation procedures, and you may have to do some more things with these cases, as I'll show you subsequently. So for these three types, we usually recommend what we call as percutaneous cement augmentation procedures, and out of these we have got majorly vertebroplasty and kyphoplasty procedures, which we'll learn more. So augmentation techniques are basically procedures that are used to treat painful progressive vertebral compression fractures, and what we do in these cases is inject some degree of viscous bone cement into the fractured vertebra to fill the crevices. There are different methods how we do it, we'll learn more. So when we talk of vertebroplasty, that means that we inject bone cement into the fractured vertebra directly without creating any new cavity. Whatever fracture is given to us, the pattern, we just use that, put a needle. We'll talk about how we put the needle, guiding, and once the needle is correctly positioned, then we start injecting cement, either with small syringes or with a special vertebroplasty kits, where we have to inject more liquid cement because there is no cavity, so we have to inject cement with pressure. So you cannot use a viscous cement to inject into this, and that is where the problems with vertebroplasty, that is the kind of cement leakages, etc., they come. They are slightly higher when we compare it with kyphoplasty. So common vertebral fracture sites we all know is between the lower thoracic and thoracolumbar junction, T8 being one of the most common. Most of them occur spontaneously, and most of them are occupied with accompanied by some degree of pain. Radicular pain is not that common, but in a reasonable large number of cases you will find that the patients talk of girdle pain. So girdle pain or pain along the L1 dermatome or in the groin, especially when it is a L1 fracture, that should give rise to suspicion that you are dealing with a vertebral compression fracture. So what are the morbidities when we are talking about compression fractures? There is a fear of falling. The patient start using some kind of a aid. The biomechanics of the spine tend to get altered. And they will trigger some muscle spasm, and because the spine is held in a kyphotic position, the facets getting overloaded, they are leading to overload failure of the facet joint, arthritis, and this sets in a cascade of negative changes in elderly patients, and they develop decreased exercise tolerance and ultimately depression and other complications which are related to confined to bed. So if we look at treatment for simple fractures, we already said that the conservative treatment in the form of bed rest, pain control, some kind of heat or cold packs. Usually I personally don't recommend any massages, but some treatment guidelines do talk about them. Bracing is quite helpful, as in when the patient is able to tolerate use of brace and sit upright or stand upright to walk and go to the washroom, because that is one major activity in their daily life that they are very apprehensive about. So that is our duty to give them that particular thing back, to take care of their daily needs of washing, cleaning, etc., all by themselves. Otherwise they feel very low, depressed if that is withheld from them for a long time. Surgeries are usually not indicated except in the cases which I just already deliberated. So if we treat them with bed rest, pain control, braces, as I said, then but that requires decreased activity. The moment you give bed rest, that means you have to decrease the activity of the patient. So what decreased activity does? Unload the spine from routine loads, which ultimately further reduce the bone density and further increase the risk of fracture. So this tends to set in a vicious cycle which doesn't have any end. So wherever feasible, either you decide upfront that this fracture is stable, I have to give a pain control. The moment the patient's pain levels come down 50-60%, you try to make them upright because you're confident about the fracture being stable. And if the fracture is not stable, in your initial assessment, confidently recommend a procedure These days there is no bar of waiting 2 weeks, 3 weeks before you recommend kyphoplasty, especially when we are talking of kyphoplasty. When vertebroplasty, yes, because the cement can leak through the initial crevices, but if you are creating a kyphoplasty cavity, usually it's a very safe procedure. We have done them within first 2-3 days of patient sustaining injury without any major cement leaks. These were the options which were available earlier when we were treating these osteoporotic fractures, but nowadays with the advent of percutaneous techniques, these cases becoming less and less common. Of course, certain fracture patterns like burst fracture or unstable fractures still would require these kind of long constructs. So in vertebroplasty, we do vertebro as well as kyphoplasty under local anesthesia, is usually as a daycare procedure, and hardly any bed rest required. Immediate pain relief, because the moment you fill the fracture, the micro movements are reduced drastically and the patients can be comfortable. Risks are least if patient proper selection. This holds true for almost all procedures that we do. So if you go back to the history of vertebroplasty, initially actually it started in France for hemangioma treatments, but ultimately it got much more popular for treating compression fractures rather than only hemangiomas. It still is being done for tumors in some cases, and there is no absolute time frame required. Painful vertebral fractures with Kummel's lesion or osteoporotic fractures are good candidates for vertebroplasty. Sometimes in unaffected vertebrae, we do put a little bit of cement basically to offload the load in multiple levels vertebroplasties, or if there is some kind of a load shift between two adjacent segments. If you suspect there is a infection, absolute contraindication for vertebroplasty, you put cement and you invite disaster. So be sure that the patient does not have any element of infection, the telltale signs of constitutional symptoms, and if the patient is starting to improve with medication and bed rest, that again becomes a contraindication. You don't need to intervene. If there is a large fragment which is occupying more than 20-30% of the spinal canal, again not a good indication. And if you find that there is a posterior cortical breach, in the beginner's hands, usually it's not a safe procedure. Some advanced users can overcome this limitation, but that is not a very good indication. Tumors invading the epidural space, which is causing more than 90% of body collapse, which we call as vertebra plana, and extensive fracture of surrounding bony structures, again is not a good indication for vertebroplasty. How does vertebroplasty work? So we know how we need to understand that what is the pain mechanism for vertebral osteoporotic fractures. It is the irritation of the nerve endings in the periosteum as well as within the bone substance, what if they are, and compression of neural tissue by the mass effect, and microfracture which will weaken and thus cause pain through stretch of the nerve endings within the vertebral fracture or the lytic tumor mass. So when we introduce cement, which is an exothermic cement, it is a heat producing cement, bone cement, which is PMMA, that is commonly we use polymethyl methylacrylate. Thermal necrosis of nerve endings will kill the pain fibers. Toxic effect of cement monomers on the tumor cells will also reduce the tumor mass, and stabilization of microfractures help prevent vertebral collapse and improve the pain. Patient evaluation, you have to evaluate detailed history, associated underlying disorders you need to rule out. We already talked about basic exams, and we do it under local anesthesia, but the patient is lying prone with all monitors, IV lines, etc. for any eventuality. We tell the patient that if need be, we may have to give you general anesthesia, especially if the cement leaks and there comes a situation where you have to do a laminectomy to remove the cement for neural deficits. When we talk of complications with cementing procedures, most of the complications are relevant to vertebroplasty. Of course, they can be projected to kyphoplasty too, but I'll tell you the difference between the two, then you'll be able to understand. Nerve root injury or spinal cord injury, though rare, is still documented. I have personally witnessed people doing it, and then there is no scope. We can't just come out of it, because the moment that cement leaks into the canal or close to the nerve root, it is not only the mechanical pressure but the thermal damage that it causes. Even if you remove the cement after that, it may not allow any recovery of the neural function. So the best way is to prevent the neural damage rather than to treat it. Pulmonary embolism can happen, so you have to watch for, monitor, tell the anesthetist at the time of cement injection, watch for saturations, watch for any change in blood pressure and oxygen parameters, and if that happens, give some steroids, be prepared. Hematomas, rib fractures by needling, etc. can happen, abscess if there is an infection. respiratory arrest because you are doing it under sedation, so you have to watch, and these are elderly patients, they may not have too good respiratory controls. If you are doing vertebroplasty for cervical spine, then you are going close to the esophagus, the patient can have some kind of a dysphagia, and massive pulmonary embolism can happen. It has been documented, leading to loss of life and thermal injury due to polymerization. So you have to watch for these complications, have to talk about them to the patient. Of course, the incidence is rare. You have to reassure them that though this is mentioned, but the incidence is rare. This shows, the complication rate is between 1 to 10%, and major complication rate is actually 1%, close to 1%. Minor complications of minor leakage can be seen, which may not be clinically relevant or significant. This is just an example of a vertebroplasty. You can see just plain cement injected into the vertebra. Now, we already learnt about what kind of complications can happen with vertebroplasty related to cement leakage and other things. So to overcome these complications, the technique of kyphoplasty was invented. So what is the difference between kyphoplasty and vertebroplasty? The essential difference is that it first creates a cavity within the fractured vertebra before we inject any cement. So by creating that cavity, we are crushing the bones against each other, so the end plates are getting sealed by the balloon, and then the cavity which is created allows a more thick cement under low pressure to be injected within the cavity. It has its flip side also, because in vertebroplasty the cement interdigitates very well within the crevices, whereas with this cavity kind of a thing, the interdigitation is slightly less. But if you look at the trade-off of safety versus benefit, then the safety is much higher with this particular thing, because since the advent of kyphoplasty, the number of the incidence of cement leakages have gone down significantly, and the safety has become, and its acceptance has become very well, it is widely accepted after that. So as I said, more viscous cement can be injected, and with less chance of cement leakage. An additional benefit of kyphoplasty is that you do get some kind of height restoration of the fractured vertebra to some extent. May not be as much as was initially claimed when Kyphon was introduced, the balloon kyphoplasty system, but yes, it still does some kind of height restoration. So what is the benefit? The amount of kyphosis that happens with each vertebral fracture, that is limited, and we know kyphosis begets kyphosis. So if the kyphosis is there, the adjacent vertebrae will be at a much higher risk, 3 to 10 times in various studies, to sustain a new osteoporotic fracture within the next 1 to 2 years. So if you can reduce the incidence or degree of kyphosis, you can prevent subsequent adjacent fractures. And correction and prevention of kyphosis not naturally. So coming to the technical aspect, how we do it, the first thing is that you have to do a very good AP and lateral X-rays, C-arm views in position. The patient is lying prone, patient is under mild IV sedation along with local anesthesia. You visualize the two pedicles very clearly, and you start, and normally I do a bipedicular approach. Some people use only a single pedicle, and then they are able to position this needle right up to the center, and they can inject cement across. But in our hands, we find that bipedicular approach gives a much better cement augmentation, which is more uniform and more end plate to end plate type, which gives good strength to the fractured vertebra. So what we are talking about here is that we start in the right side, it is at 1 o'clock, in the left side it is at 11 o'clock. If you look at these pedicles, these are the pedicles, large magnified pedicles are seen here. So we start the needle initially at the 11 o'clock or 1 o'clock, gradually, because these are soft bones, so you don't have to use a big hammer. But if you still find that your initial needle is getting slipped because of the lateral surface of the facet, so you can just torque it and maybe start with a gentle tap, and once the needle is engaged in the bone cortex, then you can gently slide it in. You have to constantly watch two things. One is this, the medial border of the pedicle here. So again, the same thing that I was talking about, you have to collate AP and lateral views, where your needle tip is lying in the AP view and where it is lying in the lateral view. So in AP view, it should be well within the center of the pedicle when the tip is already touching the posterior vertebral border. So if you can achieve this picture, that means you are safe, because the pedicle is away, the canal is still here, and the needle is already entering the vertebral body. So if it is not so, then you are in danger, and then you have to correct it. And mind you, if you happen to have a wrong needle position in the beginning, it is different from doing endoscopic discectomy than kyphoplasty or vertebroplasty. If you suppose you find during procedure that you have violated the medial wall of pedicle, you can withdraw and go in, But remember this fact that there is a higher chance of leakage of cement along that previously created track. So be aware of it. Any trickle of cement coming posteriorly, it should alarm you. So be very well aware of this particular thing, that if you have to reorient your needle during procedure, there is a higher chance of leakage of the cement into the canal. So be very alert about this thing. So once this needle is positioned here, we can safely push it further right up to this part, that is posterior 1/4 of the vertebral body, and as shown here. And here, once this needle is somewhere here, you can see that still the medial wall of the pedicle is still intact. It has not been violated. So this is the ideal position for putting a needle for kyphoplasty. Once this is done, you remove the stylet, then through that you put a guide wire. Over the guide wire, you put a dilator, and over the dilator, in this case, what we do different than vertebroplasty is this. So we use this hand drill. This serves twin purposes. So you can see it's one, it will help create cavity, and then it will, if you just hold the needle and try to hold it against the wall, we can get some kind of a bone sample, especially if you are dealing with a pathological fracture. So you can see a small piece of bone like this. You can do 1 or 2 drills and you can take out a bone sample for histopathological examination. So once the drill has been done, you introduce these 2 balloons. You can see these 2 markers of the balloon bilaterally. The cavity has been now created. You can see the white void here on the X-ray. It is very much visible. You inflate the balloons to still widen the cavity and crush the superior inferior end plates for better fixation. And then you see these balloons which are trying to touch each other in AP view. This is a very ideal location of the balloons. So they are approaching the midline. That means your cement also will tend to come in line and then bridge and touch each other. So providing you a uniform support. So once you take out deflate the balloon, then you take them out, then you start these bone filler devices, which are not cement, they are not with syringe, but they are mechanical metal bone filler devices you will see in the workshop. So you fill those cement devices, usually 2 or 3 on each side, but the last ones we usually fill half, because sometimes if you are not able to inject the cement and you have to leave half of it, it may leave a tail of the cement which looks ugly on X-rays, and sometimes it could be irritant to the muscles in the posterior paraspinal musculature. So you start with the anterior part. First the BFD, the bone filler device, goes right in the anterior part of the cavity. You start injecting. Now this is the most important thing that you have to learn from this workshop. Every single 0.1 cc of cement that goes inside the vertebra has to be seen on fluoroscope. You cannot be lenient, you cannot be lax when you inject cement into the vertebra. You will never know when it would leak either into the vascular system or into the new epidural space. So every 0.1 cc of the moment you inject, you watch. A lot of times, sometimes you have to do a constant fluoroscopy when you are injecting more cement in one go. So if you are injecting more, watch fluoroscopy. If you are going incremental, inject, see, right, left, separate. So the moment you see the cement is not going in the intended direction, that gives you an opportunity to correct. And in all my patients, I always tell that if I find during procedure the cement is going at the unintended place, I will rather abandon the procedure instead of going ahead with it and risking a major catastrophe. So you start injecting, start watching, gradually you withdraw your BFD, filling the anterior, because once you start filling here, you can't go front, but you start filling here, you keep on withdrawing, and as you can see, step by step, first the anterior part, then the middle part, and then you can see a very nice cementing from right to left and from superior to inferior end plate. So this is a usually ideal execution of a kyphoplasty procedure. I also use this particular technique in older fractures where patients come to you 2 or 3 months later and still complaining of pain. If you look at a standard X-ray, you will see that this is a vertebra plana, and it may not be suitable for a kyphoplasty or vertebroplasty picture, but you ask the patient for a sitting and a lying down X-ray, so you can see the fracture is still opening up. So this gives you some opportunity to treat these fractures with percutaneous procedures. So they can be very nicely done as shown here. The same case, getting the height which was being available and lying down X-ray as compared to a sitting X-ray. Usually you have to confirm your fractures by looking at the T1 and STIR sequences. This is again another important tip. Always look for STIR sequences, always look for T1, because many a time this area could show some kind of edema, especially in T2 weighted images, if these are modic changes. But if the patient has a acute fracture, it will show this black signal on T1 weighted, and similarly it will be confirmed on the STIR, SAG and coronal section. So that confirms that it is an acute fracture and is amenable for any kind of cementing procedure. Again, an example of a 85 years male. In this case I have just showed you here. Why? Because you can see some kind of a screw marks here. This is we had operated him 4-5 years ago for lumbar canal stenosis. He was doing fine, but then he fell one day for 4-5 years later and broke this L1 vertebra. Now in this case we recommended a kyphoplasty, but because this was a stiff segment, this was going to be stiffened by the cement, so we had a additional stress riser here. In this case what we do is preventive vertebroplasty of the intervening fragment, so that it gives some kind of additional stability to the normal vertebra. Otherwise it has a higher chance of breaking very soon, lying between the two stiff segments. And we can also combine a kyphoplasty if we suspect that there is an intravertebral instability. By intravertebral instability we mean that the end plate is broken, there is a lesion here within the vertebra, so you can do a kyphoplasty and then percutaneous pedicle screw fixation to allow that cement to heal. Thank you.
Yeah. Any questions?
So in case we breach, the pedicle medially.
Pardon?
In case we breach the pedicle medially.
Yes.
So is it more prudent to go unilaterally or redirect the needle?
Actually, if you are not very confident, yes, it is prudent to go unilaterally, but do remember that if the fracture is continuous, even through the other side the cement can leak through that track. So whenever you breach the pedicle medially, be very, very extra alert
We
of
have not
look.
crossed the pedicle.
Yes.
Yeah. Second is, so the filling of the cement is bilaterally done?
Yes, we usually do. There are two, a surgeon and assistant. So we do 0.51 cc, 0.1 cc watch. Again, watch it step by step every time.
And how long is the fluoroscopy exposure otherwise?
That's pretty high. We've not timed it, but yes, in these procedures it's pretty high. Because every step you have to see. You can't miss even one single step.
Thank you, sir.
Surely you have to protect your balls. Okay, now we'll thank you very much, sir, for the lecture. Now we'll break for tea, and then we'll move for the demonstrations. And you can see all the demonstration going on in the cadaver lab on